Okay, we know that from the literature, we know that invasive or non-invasive positive pressure ventilation is an established treatment of severe cardiogenic pulmonary edema. And this was demonstrated by many papers. For example, this paper published years and years ago by Dr. Burston regarding CPAP. So we also can imagine that weaning-induced pulmonary edema may develop and may be a cause of weaning failure in predisposed patients. And this is what we observed years ago with François Lemaire in this paper. We observe an increase in POP, pulmonary arterial occlusion pressure, when we shift the patient from mechanical ventilation to spontaneous ventilation. And many other papers confirm this observation, that is to say, an increase in wedge pressure. But in this study with François Lemaire, we not only measure POP using a Swan-Ganz catheter, but also we measure volumes using isotopes, and in particular, the left ventricular and diastolic volume index on the x-axis. And what we observed that there is no one single mechanism explaining the increase in POP, but multiple mechanisms. For example, some patients exhibited a huge increase in POP with a little increase in volumes. Other patients increased both volumes and pressures. So probably there are many mechanisms. And in this review article cited this morning by Antonio Pesenti, I tried to explain what could be the mechanisms. In fact, if we start from the top of the slide, we have 5 primary factors which could explain the increase in left ventricular and diastolic pressure and therefore the occurrence of pulmonary edema. The first one is decrease in intrathoracic pressure during weaning. The second one is the increase in adrenergic tone because of the emotional stress created by weaning in these patients. And also because of the increase in PCO2 in some patients. So PCO2 is one of the mechanisms, one of the factors. Also the decrease in PaO2 in some patients during weaning can be responsible for the occurrence of pulmonary edema, and also the increased work of breathing. It is a very important mechanism which could be the trigger for cardiogenic pulmonary edema, as we will see. In fact, these 5 primary factors can be responsible for increase in left ventricular and diastolic pressure through 3 mechanisms, which could be increase in afterload of the left ventricle, increase in preload of the left ventricle, or decrease in compliance of the left ventricle. Regarding the preload, 4 of the factors, decrease in intrathoracic pressure, increase in adrenergic tone, increase in PaCO2, and decrease in PaO2, can be responsible for the increase in systemic venous return. And this can be responsible for the increase in preload of the left ventricle. And therefore, if we now remember the diastolic function curve of the left ventricle, with the left ventricular endoscopic pressure on the y-axis and the left ventricular endoscopic volume on the x-axis, we generally have, during weaning, an increase in preload. But if you look at that, this increase in preload cannot be responsible for a huge increase in pressure if the ventricle is normal. But if the ventricle is previously dilated, the same increase in preload created by all the factors that I described, the same increase in preload can be responsible for a huge increase in pressure and therefore can be responsible for pulmonary edema. So the previous status of the left ventricle is very important for explaining the consequence of increasing preload on left endoscopic pressure. And probably this is the mechanism explaining the cardiogenic pneumoedema occurrence in this particular patient with increase in volume and increase in pressure. And as you can observe, volume is already increased in this particular patient. Another mechanism can be the increase in afterload of the left ventricle. And yesterday, Michael Pinsky and Sheldon Magda also emphasized on this mechanism. The decrease in intrathoracic pressure can be responsible for an increase in afterload of the left ventricle, and also the increase in adrenergic tone can be responsible for, because the increase in adrenergic tone should increase the systemic vascular resistance, should increase the blood pressure, and therefore can impede the ejection of the left ventricle. And in this study we performed years ago with Christian Richard, we measured LVEF, not using echo, but using isotopes during the weaning process in COPD patients without any coronary artery disease. And we observe in every patient, we observe a decrease in LVEF during weaning. And when we placed the patient on mechanical ventilation again, the LVEF returned to the baseline value. In other words, we had a decrease in the systolic function of the curve of the heart, but which was not explained by contractility, but by afterload, because we also assessed contractility with another means, and in fact we concluded that left ventricular afterload was increased in this patient, and this could be responsible for decrease in LVEF and in some patients for the occurrence of pulmonary edema. And another mechanism is a decrease in left ventricular compliance. And this can be explained easily, because if you have a shift of the LV diastolic function curve during weaning, even a small increase in preload can be responsible for a huge increase in pressure. And we have had probably this patient, at least this patient, had this experience this mechanism because we observe a small increase in pressure and a huge increase, a small increase in volume and a huge increase in pressure. And what about the mechanisms responsible for this? We can have a myocardial ischemia or biventricular interdependence phenomenon. Regarding myocardial ischemia, we can have many factors explaining the occurrence of myocardial ischemia during weaning. Increase in adrenergic tone, increase in PaCO2 in some patients, and decrease in PaO2 and increase in work of breathing, because increase in work of breathing should increase cardiac work. And this can create some myocardial ischemia in some predisposed patients, of course. And regarding RV dilatation and biventricular interdependence phenomenon, this could be explained by increasing systemic venous return, of course, plus the increase in pulmonary vascular resistance. And in these patients, in general, there is an increase in the pulmonary vascular resistance, which could be explained by the increase in PaCO2 and decrease in PaO2. So we have many mechanisms. And now I want to go into some clinical aspects. When should cardiac-related weaning failure be suspected? In fact, it is easy when congestive heart failure and COPD coexist, and when all the obvious causes of weaning failure have been discarded. And how to diagnose weaning-induced pulmonary edema? We have to perform a weaning trial with a TPs or low level of pressure support, and what to monitor. Can we use PA catheter? Sometimes yes, and if you do this, you have to pay attention to the increase in POP, of course, during the weaning trial. Can we use other devices? For example, transpulmonary thermodilation devices? Yes, we can. And if you do that, you have to pay attention to elevation of extravascular water. And this is a study we performed with Martin Dress and Xavier Monet, and recently published, and we measured extravascular lung water during weaning. And we also measured POP using a PA catheter. And we defined weaning-induced pulmonary edema by the existence of dyspnea during weaning plus increase in POP above 18 meters of mercury. And we also measured extravascular lung water using a PICO device, and we observed that patients who increased their extravascular lung water by more than 6%, in fact, had pulmonary edema diagnosed by PA catheter. So it is easy to do. Can we use Doppler echocardiography? Yes, we can. And if we do that, we have to pay attention to the E over A and E over E prime ratios, which are assumed to reflect POP, as Frances said this morning. And you have to use an apical four-chamber view, and you can use pulse wave Doppler, and the transmittal, you have to assess the transmittal flow, and to measure E and A waves, and also using the tissue Doppler, you can measure the E prime wave, and you know that the ratio E over A and E over E prime can reflect left ventricular pressure. And this is a study we performed with Bushra Lamia in our unit some years ago, and we measure E over A and E over E prime ratios during the weaning process. And we measure this ratio at the end of the weaning trial. And what we observed that patients with pulmonary edema diagnosed with a PA catheter at that time, PE+, in general had higher E over A ratios than patients without pulmonary edema during weaning. But we observed a lot of false positive cases. And also, using E over E prime, measured at the end of the weaning trial, we also measured some false positive cases. So we concluded that the predictive value of each of these variables was not sufficiently acceptable to diagnose weaning-induced pulmonary edema. But when we combined both E over E prime and E over A ratios, we observe very good sensitivity and specificity to diagnose pulmonary edema. And so the combination of E over A above a certain level, 0.95 in this study, and E over E prime above 8.5 at the end of a spontaneous breathing trial predicted weaning-induced pulmonary edema with a high accuracy. Can we use BNP or NT-proBNP? Maybe. But when we performed this study with Martin Dress and Xavier Monet, we were a little disappointed because we did not find any difference in terms of BNP level before the weaning trial in patients with weaning-induced pulmonary edema and patients with no weaning-induced pulmonary edema. And pulmonary edema, again, was diagnosed with a PA catheter. So there was no difference. We only observe a difference in terms of changes during the weaning trial. So patients who increased their BNP during the weaning trial, in general, had pulmonary edema during weaning, diagnosed by the PA catheter. But the area under the curve, the row curve, was not so good, 0.76 for delta BNP. Can we use other tests? Yes, we can. And for example, we can use hemoconcentration indices. What is the hypothesis? The hypothesis is that during hydrostatic pulmonary edema, you should have hemoconcentration because you have a transfer of plasma without proteins from the vascular compartment towards the interstitium and alveoli compartment. Therefore, you should have hemoconcentration during the hydrostatic pulmonary edema process. And therefore, we should have hemoconcentration during a weaning-induced pulmonary edema. So it is very easy. You measure plasma protein concentration or hemoglobin concentration before the test and at the end of the test. And you have the answer. And this is what we did with Nadia Engel and Xavier Monet in patients with weaning-induced pulmonary edema and patients with no weaning-induced edema, again diagnosed by the PA catheter. And we observed that patients who increased their plasma protein concentration by more than 6% during the weaning trial, or their hemoglobin concentration by more than 6%, in fact, had weaning-induced edema. So it is very easy to do. This is what we do every day for every patient with a weaning trial. And it is better, delta hemoglobin or delta plasma protein concentration is better than delta extracellular water and delta BNP for diagnosing weaning-induced edema. And just, one word about passive leg raising, because it could be used to diagnose weaning-induced edema. In fact, if there is no response to passive leg raising, it means that the patient is preload independent. And maybe this phenomenon can occur in patients with weaning-induced edema. This is a hypothesis we tested with Xavier Monet and Martin Ress recently, and the paper was published, I think, this year, excuse me. And we measured cardiac index with a pulse control analysis device, the PICO, during passive leg raising. And we observed that patients who increased their cardiac index during passive leg raising had no weaning-induced edema diagnosed by a PA catheter. And the opposite was true. So it could work very well. And the cutoff value we found was 10%. So it is very easy to remember patients who do not increase their cardiac index by more than 10% could have weaning-induced edema. So now, very briefly, which therapy? If you diagnose weaning-induced edema, can you use diuretics? Yes, you can, if you assume that the main process is increasing preload, secondary to increase venous return. This is a nice study performed by Armand Mekonso-Dessap. It was a multi-center randomized study. They included many patients, 150, two groups, two arms. One was a standard therapy, and one was a BNP-driven therapy during the weaning trial. So they measured BNP, and they acted according to the level of BNP, giving diuretic, etc., according to the level of BNP. In the other groups, there was no protocol. And interestingly, they found that the duration of mechanical ventilation was shorter when they used BNP in this randomized study than when they use the standard therapy. And this effect was mainly due to patients with left ventricular dysfunction, confirming that probably these patients are predisposed to have some weaning-induced edema, as I explained before. So diuretics can be used. Also, we can use nitrates if we have some suspicion of myocardial ischemia or of increased LV afterload. Also, other vasodilators could be used. And or in terms of ventilatory modality, I think that we can use pressure support plus PEEP, decremental levels of pressure support while keeping 5 to 8 centimeters of PEEP, and we can do that during the weaning process, and we can continue after extubation in this particular population using the facial mask. So my conclusion is that in case of pre-existing cardiac disease, weaning failure from cardiac origin is not uncommon, and the mechanisms are complex and intricate and creating some vicious circles sometimes, and this is generated by marked increased respiratory muscle activity and decrease in intrathoracic pressure. And its recognition is very important, since a specific therapy, after individualized evaluation, this is very important, can result in successful weaning. Thank you very much for your attention.